This is Barbara Cochran. I am the director of the Deterny Center for Healthy Aging here in the School of Nursing, and as always today I'm representing the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this geriatric healthcare lecture series. And a reminder to the remote sites to contact your site coordinator if you have not completed a profile form yet. Also, if you are wanting continuing education contact hours, your site coordinator has a form that tells you how to access the online registration for continuing education hours. These lectures are also posted on our Northwest GWEC website, and along with about 80 other lectures from past series that you may be interested in. The lecture today will probably be posted within the next 48 to 72 hours. So if you have colleagues who are very disappointed that they couldn't make this lecture, you can let them know that, and I'll put into the chat box the website link for accessing those lectures. Today I am very happy to introduce to you Dr. Wayne McCormick. He's a board-certified physician in internal medicine, geriatric medicine, hospice and medicine, public health, and general preventive medicine. His research focus is health services research and epidemiology of dementing illnesses, both Alzheimer's and other dementia, so very appropriate for this series that's focused on ADRD issues. He also addresses other chronic diseases, including HIV infection in older persons. He is medical director of several local organizations, including hospice and long-term care facilities, as well as the founding director of Bailey Boucher here in Seattle, and he is the director of the Division of Gerontology and Geriatric Medicine here in the School of Medicine. And today he's going to talk about end-of-life care for patients with dementia, both palliative care and hospice. So take it away, Dr. McCormick.
Great. Well, welcome everybody. I've given a similar talk a few times over the past few years, and Barb assures me that often there's a lot of new attendees. And it's interesting how end-of-life care, both hospice and even death with dignity or aid in dying, has become impertinent to a lot of the West Coast of the United States. So that's changed over time as I've given this talk over the past few years. We can talk a little bit about that, but what I'm going to address today is specific to people with dementing illnesses, primarily Alzheimer's disease, but any form of dementing illness in older individuals, and how we might apply principles of palliative care and hospice to those individuals. So let's start with a case to ground our discussion, and I'll have maybe a couple of cases peppered through here. And I want to encourage people to ask questions or make comments, because practice may vary across the Willamette region in the West Coast. This is about a 97-year-old woman with Alzheimer's disease, at least over the past 12 years. It's always hard to know when Alzheimer's disease begins. Some people think it begins at birth, but regardless, she started having visible memory issues at least a decade ago, if not a little bit more. She's a retired professor, and she has one daughter who is a nurse. I should say a retired nurse because her daughter is 72. The patient has become pretty debilitated. She's dependent in all basic activities of daily living, is incontinent, used to be quite a verbal person, and is now mute. Doesn't really utter any understandable words, but smiles. Does not seem to be in any distress or suffering any way. Seems quite calm, just doesn't say much. Her normal weight's 130 pounds. She now weighs 110 pounds. And her daughter and grandson ask about hospice and comfort measures, and in addition state that, she's not really interested in food. What can we do about that, if anything? A little bit worried about her not eating and weight loss. So, might as well start with the most controversial thing up front. And again, interested in your thoughts about voluntary stopping of eating and drinking, otherwise known as VSED. Some people call it voluntary cessation of eating and drinking. It's been a subject of a lot of controversy and literature, and even a whole lot of in the lay press. I draw your attention to a New York Times article in October of last year by Paula Spann, who talks about her own mother and their journey through voluntary cessation of eating and drinking. And there's a lot of information on a couple of websites here about this, but suffices to say that this has become a fairly common thing talked about in dementia circles, at Alzheimer's disease, Alzheimer's Association support groups, and that kind of thing. And it's becoming a common thing to appear in people's advance directives. In other words, they might say, look, as I become more and more not in charge of my faculties, more and more demented, if I get to a certain point, it's okay to just not offer me food or drink and let me coast out comfortably. Lots of difficulties with that because the course of Alzheimer's disease and lots of dementing illnesses is very long, and that the individuals who say that, when they're less affected by the disease, gradually become different people. I told you about this 97-year-old who was a retired professor, was very articulate when she was professional in her younger days, but now really doesn't say much of anything. Seems comfortable, seems almost happy sometimes, just doesn't say anything. Is that the same person who 12 years ago said that if she ever got a certain way to stop feeding her? That's a difficult thing to think about, isn't it? And to contemplate for your loved one. With regard, so I'll let you ponder that for a little while. We can talk about it as the hour rolls on. But let's talk a little bit about hospice. I know that there's a number of hospice providers on the site, and a lot of you probably know quite a bit about hospice. But suffice to say that wherever hospice is provided, it's interdisciplinary care, usually carried out in people's homes. It's not a place, although of course there are bricks and mortar hospices here and there, just not many of them. So especially across most of the western U.S., hospice care is delivered in somebody's house, or maybe their assisted living or home or nursing home. Primarily concerned with making sure people are comfortable physically, pain management, supporting of caregivers, grief management, anticipatory grief management near the end of life, and bereavement afterwards for family members, for people with any life-ending illness, including dementing illness. But there's a number of things that hospice is not, and I bet some of you hospice providers on the site resonate with this. It's actually not about dying. Everybody thinks hospice is about dying. I suppose it is a little bit, but that's not what it's mainly about. It's actually about high quality living right now in the present moment. How can we make today the most comfortable, high quality it is? And keep that going as much as possible. So sure, it's about symptom relief, but it's also support of the family, and just let's make today a good day and do whatever it takes to do that. It's usually not about pain, actually. Most people on hospice on any given day are actually not in a lot of pain. A substantial fraction, about 15% here in the Seattle metropolitan area. When you're on hospice, you get something delivered to the home called a comfort kit that contains morphine and lorazepam and a number of medicines for bowel management, those kinds of things. About 15% of comfort kits are never opened. They just don't use them. People may or may not use their own pain meds, but a substantial fraction of people actually don't experience pain near the end of life at all. And then a substantial majority who experience a bit of pain, it's actually quite easy to manage with fairly modest amounts of medication. A small fraction of people need very aggressive pain management near the end of life. And hospice is built to be able to go the extra mile and deliver that. But, you know, by and large, on any given day, if a nurse case manager is managing dozen and a half people, it's not unusual for none of her patients to be in pain on a given day, or his patients. It's not just about the client or patient. Some of you on the site may be familiar with the one organism concept, and that is hospice teams are very much interested in caring for the patient or client and anyone surrounding them, any and all loved ones or associated people, and actually thinking about all those people together as kind of a separate living thing, a separate organism. The idea is to get the entire organism through the end-of-life event, and to make sure that after that happens, people remain healthy, they grieve appropriately, and look back years from then and say, you know, we did the best we could with the information we had, and we're not mad at each other, and, you know, we grieved appropriately, etc. So it's really about the health of that ephemeral organism that's made up of all the people surrounding the patient, and of course to make sure the patient gets through it in the best way possible. Hospice is not just about the money. In fact, it's a lot of hospices are not-for-profit and have a strong mission to serve. A lot of for-profit hospices actually have a pretty strong mission to serve. And it's quite common to serve patients for free. So it's one of the few medical organizations and engines to actually support people that way. So that happens with some frequency, but usually it's supported by Medicare, Medicaid funds, or private insurance. Pretty much every insurer on the West Coast covers a hospice benefit. And I mentioned before, it's not about a place. Yes, there are a few bricks and mortar hospices, but it's usually a roving, nomadic function that the care team undergoes wherever the patient lives. The goals are self-determined life closure, a sense of choice, a sense of control about what is or is not happening, safe and comfortable dying, effective grieving, and then who is eligible for hospice? Well, basically a physician is asked, or a provider is asked, to certify the patient's prognosis is 6 months or less. That's becoming more comfortable for many providers. I understand it's just, basically the prognosis is nothing better than a guess, really. But most providers are pretty highly educated. They don't like to be wrong. They might be a little bit uncomfortable with guessing these kinds of prognoses, and this is particularly fraught in the realm of dementing illness. It's really hard to guess somebody's prognosis in dementia. But it becomes less problematic if people meet certain criteria that are part of the eligibility criteria for hospice, which I think we hit in a minute. When counseling families about prognosis, I often think of it as kind of a point estimate with confidence interval, just like you think about in statistics. And that is, people want you to, it's not okay to say, I don't know how long your parents are going to live. People expect you to at least make a guess. And I couch it and I say, any physician will just be guessing if they do that. I might expect your mom or dad to live a few months, but it's possible they might live quite a bit longer than that. We can hope for that, celebrate if that's the case. On the other hand, we need to be prepared that something precipitous might happen, like a pneumonia, fall, or something like that. Let's get ready for that. Let's be prepared so we're not overly shocked if that does come to pass. So you see there's an estimate, a few months, an outside estimate of a year or so, and an inside estimate, wow, let's get ready in case something happens pretty soon. People are generally comfortable with that with regards to prognosis. But again, providers don't like to be wrong. And so sometimes it's hard to get that certification from providers in the realm of dementing illness. So plan A and plan B. Of course, we're hoping for the best, but let's be okay with that, but let's plan in case some things don't go as well as we hoped. Another way to turn it around and make people more comfortable with the prognosis is to say, well, would you be surprised if this individual died in the next 6 months? And if the answer is no, I wouldn't be surprised, well, that probably is legitimate then to go ahead and certify people for hospice. About 1 in 5 people admitted to hospice for any reason, but especially in the realm of dementia, about 20% or 1 in 5 do what's called graduate. In other words, they survive some certification periods. It doesn't appear like they're getting any worse, and so they come off the hospice benefit because they're just don't seem to be dying. And that's okay. In fact, you can certify, recertify, and decertify from the Medicare hospice benefit as often as you have to. So it's no big deal to graduate. You can always come back on hospice later if one wants. And again, back and forth as often as necessary. So that generally gives physicians, nurse practitioners a little more comfort in certifying people with dementia for hospice care. It's a little bit more straightforward in things like cancer, COPD, and those kinds of things. A little bit more difficult in the realm of dementing illness. But in the realm of end-stage dementia, and to some extent end-stage heart and lung diseases, there's a few things that we look for. And that is, primarily in the realm of dementing illness, total debility in activities of daily living. Bathing, eating, dressing, toileting, transfer from bed to chair, those kinds of basic things. If people are dependent in all of them, then that's a marker of likely eligibility for the hospice benefit. If people say few or no words, if they're mute, again, that's an important prognostic indicator. If they've lost 10% or more of their usual body weight, which our patient has, they started out at 130 and now they're 110, that's 20 pounds, that's over 10%. Another important marker of poor prognosis. So those kinds of things play into hospice eligibility in dementia. If the patient's been hospitalized recently, if they've had pneumonia or difficulty swallowing, again, another criterion for hospice eligibility in the realm of dementia. And these are national standards called LCDs, or local carrier determinations, but are pervasive across the United States that lend support to hospice eligibility. And even people who meet those eligibility requirements often survive for quite a while, and some people get a little bit better. Dementing illness on average is an insidiously and steadily progressive condition, but for an individual, people can get a little bit better, a little bit worse, a little bit better. It's not necessarily linear for each individual. So that's an important thing to remember. So key here is I want to emphasize that people can come off and on the hospice benefit as often as necessary, and that those kinds of criterion help people decide whether people are hospice eligible or continue to be eligible or not. The team members for hospice is generally these 5 realms of people. Usually the case manager is a nurse or a social worker, and his or her team includes volunteers. A lot of hospices often have a very robust bevy of volunteers. Nurses' aides, home health aide type individuals. Often the aide can be seen as the most important team member. They often spend the most time with the patient and family, and are a remarkable resource. What's fun about the interdisciplinary team of a hospice is how egalitarian it is, recognizing the aide as actually a very important member of the team. And then, of course, there are chaplain and clergy involved in the hospice team. A substantial fraction of people choose not to see a hospice or chaplain in this day and age, but many do. And it's extremely important for multi-denominational individuals who are comfortable with just about any faith stream to be able to support patients and families, or to muster support in the community if they don't feel like they know enough about the particular religious attachments. And the role of the primary provider, whether it's a nurse practitioner or physician, is to be a co-leader, collaborating with the medical director of hospice and guiding the interdisciplinary team and provide the physician's gaze. Truth be known, a lot of hospice providers, nurses, nurse practitioners, social workers, like their work because they're so autonomous. They really don't need physicians or nurse practitioners that much. They pretty much know their territory, know what they're doing, but often physicians can be great helpers. That's what you shoot for. You certainly hope they don't get in the way of the often tremendous expertise of the hospice team, but it is a required part of the whole shooting match. And important in the realm of palliative care or hospice is the doctrine of double effect. And it's important that families and providers understand that. We just had a talk this morning about using morphine in the setting of very advanced emphysema, and some studies that showed that it's certainly possible to do a fair amount of harm if you don't dose properly in palliative care for people with emphysema. As long as families and patients understand that morphine, for instance, can be really effective at remarkably low doses to relieve the sensation of shortness of breath for people with emphysema. At the same time, it can be dangerous. It can increase their likelihood of aspiration. It can suppress their respiratory drive. So, as long as everybody understands, look, it's potentially dangerous medicine. We'll use the smallest dose possible. The idea here is to avoid the awful sense of not being able to breathe. That's what we're aiming for. A secondary effect might be that your respirations are depressed or you might aspirate. That's not what we're shooting for. We're shooting for relief of your symptoms. So that's the double effect. The intention is to relieve the sensation of breathlessness. The intention is not to increase aspiration. So it is ethically justified to try the medicine since your main intent is good, is virtuous. And that's the principle of double effect. And that can be abstracted to just about any type of symptom relief. If one has been instructed by a loved one, look, if I get a certain way, don't even offer, it's okay to not offer me food or drink, it's all right, then there's an ethical justification for that. The primary effect being, look, I don't want to live like that, so don't help me not live like that. The secondary effect, frankly, being, well, the person's really a different person now, and what about the suffering it's inducing for you, who are now in the position of withholding food and fluid? A difficult, potentially difficult position to be in, but one you have to think through the principle of double effect. And multimorbidity. Now, this certainly pertains to people with dementing illness, and that is, it's usual that dementia is not the only thing wrong with somebody. Especially in very advanced age, often there's several important medical conditions, and the sum is worse than the parts. It's one thing to have advanced Alzheimer's disease. It's another thing to have advanced Alzheimer's disease and emphysema and heart failure and advanced diabetes. I mean, when you add up all those things, it can really shorten prognosis dramatically. So the principle of multimorbidity is just that, the principle that lots of comorbidities are really important, and it's worth taking those into account. So multimorbidity is the co-occurrence of diseases and functional consequences. The whole is worse than the sum of the parts. And if anybody's uncomfortable making prognostic judgments, it's good to bring up the fact that there's a number of things wrong here and should play into decision making. So here's the impact of multimorbidity on mortality, and you see that that's not a linear justification. That is, as more and more conditions arise, the effect on mortality is actually exponential. Okay. And here's another item that we should think about. It is the case, possibly, although there's no way to actually know this or not, that a majority of people with Alzheimer's disease in the United States actually do not carry that diagnosis. I see people all the time in clinic with pretty advanced dementing illness, and the family is wondering, well, what's wrong with mom or dad? They're just, they don't want to do anything. They can't. We're having to do more and more to take care of them. It just hasn't occurred to them that they actually have dementia or Alzheimer's disease. I know that's hard to believe, but when something occurs very insidiously or slowly, people kind of get used to it day by day. And you can ignore some pretty difficult stuff in somebody you love and care about, and have gradually gotten used to caring for them over time. Multimorbidity is often bundled into a debility or multimorbidity type set of diagnoses in hospice. Again, the same kinds of things pertain to hospice eligibility, ADL dependence, etc., impaired nutritional status. So, a number of unique benefits to hospice. It's a great way to get a lot of stuff. I mean, if the hospice benefit is one of the most beautiful benefits ever conceived, particularly for people with dementing illness, I believe. It's there's a lot of grief that goes into dementia care. For people who do recognize that they're losing someone gradually, there's a lot of loss along the way, a lot of grieving. It's not even anticipatory grieving. They've already lost a good part of how they remember that individual. So they need to grieve about that. And giving voice to that is a very important part of the grief process. So comprehensive grief support is a wonderful part of the hospice benefit. And bereavement is a wonderful part of the hospice benefit. Hospices are required to document that they are providing bereavement services for at least a year after the death of the client, which I think is a beautiful regulation. It's incumbent on the hospice to be able to deliver on that, to contact family members or loved ones periodically after the death of the client to make sure they're doing okay and offer services. The spiritual support can be really important, particularly in this day and age. People are often disengaged from formal religious services. That doesn't mean necessarily that they want to be totally disengaged. So having a venue for that to re-enter their lives sometimes is important. And here in the Seattle metro area, we're fortunate to have an organization, a parallel organization called Safe Crossings, that takes care of any children surrounding a dying loved one, including other children. So, for instance, the Safe Crossings organization, largely staffed by very talented volunteers, would take on the whole third grade class, say, of a child who's dying of a brain tumor, something like that. But certainly they'd take on grandchildren or great-grandchildren of a patient like the one I presented to you. The hospice nurses' aides are wonderful, and the volunteers are important benefits that you can get with the hospice as part of the hospice benefit. Hospice is largely paid for in most metropolitan areas by Medicare. But Medicaid, at least in the western U.S., has a very similar benefit and payment stream. And again, all private insurers that I'm aware of in the western U.S. have a hospice benefit as well. Some people pay private pay for hospice. It's uncommon, and then there is charity care for instance, undocumented individuals, people from other countries who aren't U.S. citizens and don't have these benefits. Charity care is often provided. So the challenges in the hospice setting are difficult bereavement, difficult grief, difficult symptom management, and being able to provide those at the right time and the right place. Particularly with gradual loss in dementing illness, it's hard to know when to ask about loss. So a lot of the social work team members and chaplains simply ask about it. You know, are you experiencing this as loss? Are you experiencing grief based on this or that thing that might be noticed? And goal setting, particularly if it changes over time, is a big challenge. So this pertains to the voluntary stopping of eating and drinking. You know, gradual changing of goal setting is difficult. That one perhaps saving grace of voluntary stopping of eating and drinking is, you know, you can go back on that at any time. If it seems like it's overly distressful, or if a patient can actually voice saying, you know, I said that I didn't want food or drink back, you know, a few years ago, but you know what, I changed my mind, so I do want to eat now. So you can kind of change horses anytime in the stream is perhaps very useful. The system of certification and decertification and recertification can often be kind of burdensome from a red tape standpoint, but that's, you know, that's part of the hospice benefit, and it's often harder to institute from hospital settings. So we're about halfway through things here, and I did think it was useful to come back to voluntary stopping and eating, drinking, because any time I've talked about this lately or been in forums where this has come up, in the realm of dementing illness and Alzheimer's disease, people really want to know more about it. It's something that's come to the fore in the past few years. So I thought we could spend some time on that, and actually, if there's good thoughts out there and comments about this, of any, I would imagine a number of providers on the website have actually had some experience with this. One thing that comes up frequently is, well, how do you palliate it? What if the decision is fast? And what actually happens when you stop eating and drinking? We all know what it's like to be hungry or thirsty, but there's quite a bit of evidence that a substantial number of people with advanced Alzheimer's disease, for instance, lose, at least in part, their sense of taste and smell. Food no longer becomes very interesting. People with advanced Alzheimer's disease, when it's really advanced, can kind of forget how to walk. So falling becomes problematic. And they can forget how to eat. And I know that sounds preposterous, but it is a fact. In fact, it's so well recognized that in nursing homes, for instance, and in settings that care for people with dementing illness, there are actually special tables that are hemispheres, half circles, that an aide sits in the middle and people with dementia, 4 or 5 of them are around this circular table, and they can see each other eating, and they see the aide feeding people around the table. And by the visual can help them kind of remember how to eat. Oh yeah, that's how you do it. And they'll eat a little bit more. But at some point, people become simply less interested in food and fluids, and that's pretty easy to palliate. They're already self-palliating. I wonder if anybody who's with us today has actually fasted for a long period of time, like for more than a couple of days. Many people report that it's tough the first 2 or 3 days. It can be really tough. Others report, not such a big deal. Yeah, a little uncomfortable. Stomach growls a bit the first day and a half, but after that's not bad. A substantial number of people report a few days in that there's actually a kind of a euphoria associated with fasting, even if you feel a little bit woozy and kind of dizzy and weak. There's a euphoric feeling that comes along with it. But if it's distressful in some way, often it's not that difficult to palliate medically. Some people will use benzodiazepines and other things to basically you don't care that you're fasting with medicines like Valium and lorazepam. So it is possible to palliate it to a large extent. And again, it's also possible to kind of go back on it. But it can be fairly distressful for onlookers, particularly if the patient is non-interactive. And this is where the hospice team really has to step up to the plate to help people with decision making, with goal changing or goal setting, with palliation to make people feel comfortable that their loved one is not in distress, if possible. But it does bring up a lot of ethical dilemmas because in the setting of dementing illness, if the person's really become a different person who might make, if they could, different decisions about voluntary stopping and eating and drinking. So why don't I just pause for a minute here, and we have a half a dozen to a dozen folks here with us, but there's a whole lot of people out there on the web who might be interested in comments. So Barb, and I appreciate you fielding some of the chat room comments so we can respond to them.
So here's one, and you might need to repeat it just briefly. Is it accurate that hospice now says Alzheimer's and not dementia has to be listed as the diagnosis when referring to hospice?
It's nice to have an etiology associated with dementia. Dementia is a geriatric syndrome, basically. It just means loss of mental capacity sufficient to interfere with, social or occupational functioning, loss of memory, and other types of thinking, like being able to name things, executive functioning, those things. That's dementia. Alzheimer's is one etiology of dementia. So yes, the question is, does hospice insurers want Alzheimer's to be specifically listed? By and large, yes. Unfortunately, that becomes a bit of a barrier. A substantial number of people in their 90s, who reached late 80s, 90s, or over 100, there's not just one cause of their dementia. Alzheimer's is the most common cause, but often people also have been affected perhaps by cerebrovascular disease, or perhaps they've had a long alcohol history, or perhaps they've had a head injury. They've fallen and hit their head. So it might be several different things that are actually together causing the dementia syndrome. It's okay to list all of those. And I would suggest that people just make their best guess. So yes, It's these days, it's dementia due to something else. And it's good for us to think about etiologies. That does actually help with hospice eligibility.
So from English AHAC, and I'm not exactly sure what they're asking, but they're talking about the voluntary stopping eating and drinking, and what the symptoms may look like in terms of educating people about the body's natural wisdom in the dietary process. That if the priority to brain was nutrition, the patient might state they are hungry, thirsty, etc., but at the end of life, maybe the natural progression of the condition of the disease doesn't want to overload the system.
Right. Well, yeah, that's a complex comment, but I know exactly what the person's talking about. That, how do you interpret signals, especially from people who maybe aren't able to verbalize well what they're feeling? It is true that for a lot of people very near the end of life, eating and drinking simply is not even on the list of priorities. It's not even at the bottom of the list. People simply lose interest entirely in eating and drinking. And in those circumstances, again, the idea is to get everybody through this. Some families are so grief-stricken and troubled by not feeding or providing fluids to an individual that you want to be able, for them to be able to do something. So just, a moist towel with a little bit of pudding or something on it to the lips, or, a washcloth with a little fluid in it to moisten the lips and gums, or for the patient to chew on a bit, often is great palliation for any hunger or thirst. And the family or loved ones might see that the patient actually rejects even that or pushes that away. That should be a healthy signal that that individual doesn't really want that, isn't interested in that. And again, in a way, that makes things easier. If it's clear to, even non-verbally, if it's pretty clear that the patient's just simply not interested in it, there's certainly no point in forcing it some way. But again, this really relies on the talent of the hospice team or the providers who are present to help families interpret those kinds of signals. It's great if the signal is overt, but even if it's not necessarily overt, the idea here, again, is to get everybody through the experience and for not to be guilty about how it's going down. I hope that covers what the person wanted to talk about.
And so here's another question, and I'm being asked again if you could repeat the questions, Wayne. So here's a twist to hospice care. They essentially wanted to take over the care of a patient, saying that they would give him baths and medications. But if the family did any of those things, then the insurance wouldn't cover anything. So the family ended up rejecting hospice because there were times when the patient would be incontinent at 1 a.m. and they had to give him a bed bath. Hospice wouldn't come in at 1 a.m. and then insurance wouldn't cover any of hospice care. So how do you deal with situations like this? And if you could repeat it, sorry.
Okay, well, my memory's not so good, Barb, so you got to make these a little bit shorter. Anyway, the thrust of this was a unique situation that I actually have not run into, where an insurer would not pay for hospice unless their own team rendered personal care, bathing, cleaning up incontinence episodes. So if the family did that, the hospice wouldn't be paid for. That strikes me as a misinterpretation, potentially, or maybe a lack of negotiation in getting to the bottom of the hospice benefit in that case. At least for Medicare and Medicaid eligibility, that wouldn't come up. And often it's useful and important for the hospice team to collaborate with family members who want to help. So what about if the hospice aide and the family member is doing the cleanup work? Surely that would be a negotiable middle ground in that particular instance. Again, I have never heard of them not being willing to pay for it unless the hospice team delivered personal care. All of it. So that strikes me as a bizarre, unusable mechanism for hospice care, particularly for people with dementing illness.
Okay, and then hospice the Anchorage AHEC mentions that a hospice patient really only needs an RN to visit routinely. Medicare pays a daily rate for service. One patient may only see the RN, whereas other patients have an entire interdisciplinary team visiting them and the family.
Yeah, good comment. It is true that Medicare regulations are such that a team member has to see the patient at least every other week, so once every 2 weeks. Some families, hospice is kind of an interesting thing. Another reason families often reject hospice or want to come off the benefit after a while is, it's kind of weird to have all these strangers in your house kind of traipsing through at all hours of the day. It's not unusual when people sign on to hospice to be visited by an intake nurse and then by the usual nurse who will be their case manager, and then maybe it's the social worker, and then the aide comes a couple times a week, and then the chaplain comes around. So there's all these people coming around. They're nice people, and once you get through a couple of weeks, often it's great. And sometimes a number of them are in the household, just like was mentioned by the Anchorage gang. But some people say, look, I don't want all these people coming through the house all the time. And then you can actually negotiate it down where people are visiting less frequently. If the family really doesn't need them for a while, that's great. It is true that, at least in the Seattle area, the hospice organization is getting about a little over $150 a day, whether they visit or not. And that's because hospice is kind of a group benefit. That hospice team might, again, have 12.5 patients and clients. And a few of them are very needy, needing a lot of team members in the house, a lot. And maybe there's a few who are like this, who only need somebody popping by every week or two. And then there's a bunch of people in the middle. It's supposed to come out in the wash so that the group benefit together covers the costs. So that is true. It's not required that people come by every day or any particular frequency. But, and some people just don't need it or find that they don't actually want it or benefit from it. That's okay.
So no more questions in the chat, but there might be some in the room.
Yeah.
I have a question.
Go ahead.
So when you talk about people being different, as the people as their dementia progresses, they become different people. I mean, I know lots of ways that people change in their abilities, their ability to communicate and do their activities of daily living. But can you expand a little bit more on how people are different and how they might think about end-of-life issues differently?
Sure. Yeah. The question had to do with, how are people different as they become more and more affected by dementing illness? Let me answer that this way, and that is, are some of you familiar with an author named Jonathan Franzen? He wrote The Corrections and Freedom, and anyway, very popular author these days. Had a fight with Oprah Winfrey, and she kicked him off the book club. Does that ring a bell? It was quite a few years ago. Anyway, it so happens I grew up a block away from Jonathan Franzen in Webster Groves, Missouri. So our parents played bridge together, and both of my parents and both of his parents had dementing illness, which he writes about in his books. And we talked a little bit about our parents and about dementia. Jonathan's given a lot of talks to Alzheimer's Association groups and book clubs and that kind of thing. And Jonathan's comment was, you know, as we talked about our parents, because they were very similar people, he said, yeah, you know, it's interesting, this Alzheimer's disease, it's always the same and it's always different, which I think was a very wise statement. Yeah, there's a lot of similarities to what happens to people with Alzheimer's disease over time. But each individual is entirely unique. And each family, each organism I talked about is unique. And so because of that, each care plan has to be individualized and malleable, because each patient and family does not stay the same and are unique individuals. So what works in one family for what to you look like pretty similar circumstances to another family will not work for them, because they're just built differently. And because people change over time, it's very hard to guess necessarily what they're feeling or what they would want. And they are fundamentally different human beings when they're very affected by dementing illness than they were when they were just fine years ago. You might argue, well, as we age, we become different people, but not that different. Dementia fundamentally changes the personhood, different than simple aging. And as a result, some of the ethical dilemmas surrounding voluntary stopping eating and drinking are, you know, a lot of people are putting these in their advanced directives now. When I get to where I can't go to the bathroom by myself, etc., it's okay to just stop feeding me. And I want you to do that. It's one thing to agree to that, you know, at the time, and then decide when to implement it later. When do you pull the trigger on that? Is pretty difficult, unless it's very carefully specified and there's excellent consensus on exactly what that means. Sometimes that happens. People do have good consensus, and it is comfortable. But that's uncommon, to tell you the truth. Often it's very difficult for families to know when to deal with that. I'll share a personal anecdote about that. My mom, when she was in her 50s and 60s, you know, had friends who had various and sundry conditions, and she'd say things like, if I ever get like that, just, you know, lean me up against a tree in the backyard and shoot me. That is not a very helpful advance directive, it turns out. When she was in her 80s, she had a devastating stroke. Right side paralyzed, completely aphasic. That happened suddenly. You would think that that would be the time to lean her up against the tree and shoot her, which we were not able to do. But we knew what she meant. It's similar to that, though, isn't it? When I get this way, stop feeding me. Very difficult. It's a number of things need to come together. The primary one being, it's obvious that the person has no interest in eating or drinking anymore. That makes it easy, or as easy as it can get, when it's clear the person's not interested. And that happens fairly commonly in dementing illness in the absence of any discussion of this. And in decades past, the solution for that was to put in a feeding tube, which we now know through the research, actually of some eminent researchers right here in Seattle, Joan Tino and others, that it actually doesn't do people any good to put in a feeding tube. Their prognosis and longevity is the same. In fact, it might be a little bit worse than people who don't get a feeding tube. Because in the absence of discussion of stopping eating and drinking, people who don't get a feeding tube aren't, you don't stop trying to feed them. You offer them sustenance. They might take a little, they might not. People who get a feeding tube get complications of the feeding tube. They aren't able to handle the nutrients very well or process them. And consequently, people live about the same length of time, turns out, whether they get a feeding tube or not. These days, there's more acceptance and more, I think, capability and knowledge that the waning of appetite, of thirst, is a natural consequence of very advanced dementing illness and should not be denied. In other words, when people don't want something, it's probably a mistake to force it on them. Even if they can't tell you they don't want it, by all indications, pushing things away, turning away, etc., is an indicator that's verbal, that's body language that they're not interested in that, and that should be embraced if possible.
What's the path then that happens if you stop eating and drinking, providing food and drink? Does that mean that they sort of just wind down for like 3 weeks or a month and a half or 1 week, or what's the outlook there?
Yeah, the question is, well, what happens when you actually stop eating and drinking? What's the new prognosis then when that happens? It's remarkable how variable that is. Everybody has it in their mind. Well, let's see, if you actually stop drinking, wow, you probably only got a few days, huh? I just took care of somebody last year during 2016 who stopped drinking and lived for 5 weeks. And was not eating, by the way, in the meantime. So it's highly variable. I've also had cases who stopped eating and drinking and died the next day. And you'd probably say, oh, well, that wasn't because they stopped eating and drinking. Something else was going on. Maybe so, maybe not. Hard to say. I can't say definitively one way or the other. But that's, again, it probably plays into this idea of plan A and plan B. We're going to make today a high quality day. We're going to make this next hour as high quality as possible. That means if the person obviously is not eating or interested in eating or drinking, we're just going to hold off on that. I'm going to make sure you're comfortable with that by counseling you and kind of talking it through so that you feel okay about not offering those things. If the person continues to survive and we can keep that comfort level going, we're going to celebrate every hour and day that everybody's comfortable and it seems to be high quality living. If any discomfort comes up, we're going to work on it. Let's be ready in case we start on this path and the person dies later today. Let's just be ready for that, because we're going to still keep our experience as comfortable and high quality as possible.
Do you very often see a situation where they seem to no longer want to eat or drink, and then after a period of time they get hungry and thirsty and they start eating and drinking again, and you just kind of have a little...
You bet. Very common. It's very common for people to kind of go back and forth. And a good approach then for everyone concerned, especially the family, is to go with the flow. And that's where this, a little bit, a washcloth with a little pudding on it. Washcloth that's moist so that they can just suck on it or kind of nibble on it for just a little bit of fluid, seems to palliate that. And then, maybe you start over. Then maybe they start pushing away again. You just go with it. And if that lasts for weeks or months, you go with it. You stick with the plan and be variable about it. And in the meantime, you're supporting the family as best you can. But, being kind of rigid about just about anything usually is not a very good approach with the patient or family. unfortunately, a lot of the hospice eligibility criteria and other things have a rigidity about them. Like this question we entertained a little while ago. Geez, you know, it looks like the insurer won't pay the hospice benefit if the family renders any personal care. It's 1 o'clock in the morning, the person's been incontinent, the hospice team's not coming out. Come on, what's the deal? We can't clean up grandma, you know? That's where I think negotiating directly with the insurer, this is not practical. Can we meet, you know, what's the halfway meeting point that's actually, you know, these are human beings who are, you know, answering the phones at insurance companies, and usually there's a way to negotiate that kind of thing.
Do you see, this is a slightly different question there. Do you see situations where someone, and I guess memory would be the first thing, where they basically lose their ability to remember anything 5 minutes, you know, that happened 5 minutes ago, but yet they're high functioning in other areas?
Oh, sure.
And is that something that would kind of contradict the idea that they really have Alzheimer's? Or the memory thing, really, they would actually be qualified as an Alzheimer's victim, shall we say?
Yeah.
But they could just continue to live a robust life. And I've seen a number of different people who, you know, had a pretty normal life and laughed things off and everything like that, but they just lost the memory element.
Sure, yeah. The question has to do with the variability in Alzheimer's. Some people seem to be very high functioning yet have terrible memory. There is part of Alzheimer's is now being found is something called mild cognitive impairment. That can happen with any kind of thinking. But a lot of people have isolated memory loss where they just have terrible memory, can't seem to learn anything, things have to be repeated, yet seem functioning otherwise. They can actually do their own activities of daily living. And so they wouldn't necessarily fall into the dementia syndrome. If it's not overly impairing social or occupational functioning, it's not dementia yet. Might become dementia later, often does. But yeah, again, it's always the same and it's always different. I took care of a man a few years ago who had profound dementia, very advanced dementing illness, was completely dependent in all ADLs, and he owned a restaurant. And his kids and grandkids simply put him in the chair in the corner of the restaurant, managed the restaurant all day, and took him home and put him to bed at night, and ostensibly he was running the restaurant. But was nearly mute and had very advanced dementing illness. As far as they were concerned, things were going along fine. You know, they weren't overly concerned about his quality. He seemed to have pretty good quality of life, but they were taking total care of him. And the main question then had to do with, you know, what kind of advanced directives around what do we do with a restaurant when he dies, you know, those kinds of things. So we talked about that a bit. I took care of another guy who was a physics professor, and even in his late 80s was still going to physics meetings, you know, national, international meetings, and one day flew to Washington, D.C., and, you know, that's a long flight, and we really pooped when he got there, and he couldn't figure out how to use the key card in his hotel. It just boggled the mind. He just couldn't figure it out. And it wasn't just that, though. He called his wife and was crying and yelling. And actually security got called in the hotel, had to help him out. Completely atypical of this physicist, you know, way out of the norm. And he was having memory problems and kind of problem-solving, executive functioning problems that were completely atypical for him that were impairing his social and occupational functioning. So, you know, those two cases contrast how affected different people can be given their social occupational context and how it's a big problem. A minor thing is a big problem for one guy. Major stuff is somehow not a problem for another patient and family. And they cope with it very differently. That's the fascinating thing about being a geriatrician and working with people with dementia, is how unique the problem solving has to be, and how you have to be prepared to change the problem solving along the course of illness when following people over many years. Because things do change. Problems that are very bothersome this year might go away as issues. People sometimes get easier to take care of, but new problems arise, and you have to troubleshoot those along the way.
So you mentioned about, you describe all of these things as dementia related. At what point does it sort of wander into the area where it's clearly an Alzheimer's situation?
Well, Alzheimer's is an etiology of dementia.
Yeah.
It almost, to the provider, often it's less important what the etiology is. If a person has advanced dementia, I usually don't necessarily, it doesn't impact my taking care of that person, whether it's Alzheimer's or vascular dementia or dementia related to alcoholism or dementia related to head injury, etc., or maybe some combination of those. Alzheimer's is a cause of dementia. So it's not a differentiation so much as an etiologic underpinning of their dementia syndrome. Great. Are we over time or under? What's the usual?
We have about 20 more minutes.
Oh, great. Okay. Anything coming in from everywhere?
Not really, just that was a good discussion.
Yeah, okay. All right. I went too fast.
Well,
We should-
somebody has asked if there's a way, if there's a way to tell if the patient is suffering hunger or thirst if they can't indicate it to you.
No. No, you've got to rely on your sixth sense.
Repeat the question.
I will. Is there a way to tell if the patient's suffering hunger or thirst if they can't indicate it to you? There's not inherently a way. You have to rely on your sixth sense, often with family members, on their judgment. Let's say you offer a moist towel to the lips and they don't push it away. Should we assume that they're thirsty? Hard to say. In which case you keep offering that until some sign occurs to indicate to you that they don't want it anymore. And of course, any people affected with dementia can change from day to day. Some people have good days where they're firing on more cylinders. They might be better able to indicate whether they're hungry or thirsty in a different hour or a different day. So you just try to take advantage of that and use that to the best of your ability. You may, on a given day, you simply may not know. This is where you've really got to go with the flow. Go with what the family seems to want, what the patient seems to want, etc. And that can be very challenging for hospice teams. They can be, the hospice team in many situations is also part of the organism. They're affected by the people they take care of. They might be very disturbed in seeing a family trying to force food and fluids on a patient who, in their estimation, clearly doesn't want it. Or the other way around, a patient clearly seems interested in food and fluids, even if they indicated in the past that they didn't want that, and the family seems to want to withhold those things, even though you sense their guilt and grief in wanting to do so. That's something you've just got to get all your cards on the table in that situation and talk it
Is there
through.
any legal issue in a situation like that, as far as, say like in a family, you got several kids, and some kids say, keep making them drink and eat and that sort of thing. The other one's saying, no, I think it's time to pull the plug on that. And
Sure.
can anybody accuse you of killing Nana or whatever?
Well, the question comes up, what if there's disagreement within the family? Some kids want to push food and fluids and others don't. That comes up actually all the time. Maybe not in a fully contentious way, but maybe a point of debate anyway. And again, your charge on the hospice team or as a provider is to try to forge consensus And that might take several conversations to say, look, we have some justifiable differences in approach here among the family members. It's going to be really important years from now for you to look back and to say, you know, we did the best we could, and we got as close to agreement as we could about these kinds of things. You have to be prepared to fail in that situation. You cannot always make everything nice for everybody. I took care of a family like that a few years ago. It was an enormous family, lots of kids, and they really looked up to their preacher, clergy person, who was not in the family, but was a very important individual. He was a remarkably charismatic and articulate guy who came to a family meeting, and the kids were, yelling at each other. I mean, they were really mad. So yeah, he can get pretty nasty. And in this particular instance, I said, we really need consensus from you all. And I understand that there's a lot going on here, but I'm going to leave the room and come back in like 10 minutes or so, and I want you to have tried to reach consensus. And so I left with the preacher, who was going to go back in and try to help. And the preacher's comment was, these folks have always been like this. You can't unscramble those eggs, was his statement, which I thought was pretty good. You can't unscramble those eggs. They've been that way, dealing with each other that way. They've been practicing dealing with each other that way for 50 some odd years. You're not going to turn that around in the next 10 minutes. But no harm in trying. So we went back 10 minutes later. They hadn't changed one iota. So you got to be prepared to fail. But if you make it overt that, what we need now is consensus. We need to I've laid out all the pros and cons. You all need to come to consensus. As long as they know that's the charge, they can grab the ball or not. Either way, you got to move ahead. Whether they agree or not might not change things that much. The die may be cast. You can say that to them too, but they're not going to necessarily take it in. Difficult. It's not always fun, this hospice end of life stuff. That comes up. But I'm sure all the hospice providers know it can be remarkably rewarding. When you know deep down when you've done a good job and you've got patients and families through difficult times. And that happens a lot, and that makes it a rewarding line of work.
Question.
Mm-hmm.
Can you talk some more about the following slides after this slide? Can you talk some more about what strategies you've used successfully to deal with the cultural barrier for hospice referral?
Okay. The question had to do with cultural biases around hospice referrals, and that comes up for hospice generally, and it comes up to this stopping eating and drinking specifically. Mm-hmm. Not at all unusual. And but it's very unpredictable. I've certainly had families from every imaginable sect be very embracing and open about hospice, even if they're not all that Americanized per se. But then others where it's really a foreign enough concept that they really don't ever get it. And an important thing is, unless you've personally experienced directly a hospice team's care, it's hard to envision it, kind of hypothetically. You can describe it, but unless you've experienced it, it kind of doesn't really make sense. It doesn't quite come in on your set, particularly if it's not a cultural thing that you might have some awareness of. And it comes up in regards to, so that's one thing. Signing on in the first place might have cultural barriers or understanding barriers that may or may not be translatable. I'm lucky I practice where there are actually kind of cultural mediators who can both translate but also interpret cultural differences that might make hospice or palliative care more palatable to individuals from other cultures. But then in the realm of hospice delivery, it can get difficult too. I mean, what if the hospice team is very different ethnically and culturally than the family they're delivering care for? That might create some friction sometimes, and does. That kind of friction can come up. You try to make your hospice staffers as diverse as possible, but that, for a relatively small organization, that might be pretty difficult to do. So cultural diversity can be important both directions. The acceptability of the family of the team could be problematic. The acceptability of the hospice team to a certain family can sometimes be difficult. And you just have to work with that. But you can't necessarily predict how it's going to go, I think is what I would say. So it's worth trying. And often, if you can get through the first week of hospice delivery, it usually goes fine. Some people will reject it within that first week, and you just got to go with that. But if you can get through that first week, often you're over the hump, as they say. Did that get to what you were wondering about? Mm-hmm. Okay. Well, thanks everybody for participating. I guess we'll quit a few minutes early, and I appreciate you coming and being on the site.
Thank you.
All right.
Thank you very much.
I don't hear any clapping out there on the web.
No, but this is our cue to let them know that we're done.